we are fairly limited by the number of antiemetics we have. So let's just go down this list of potential antiemetics that we can use. 5-HT3, as I mentioned, if you use 5-HT3 in your prophylaxis, it doesn't really work for treatment, so that is not a drug to be considered. Metoclopramide, unfortunately, while it's a good drug to empty the stomach, but it's not a very good drug as a direct antiemetic because it doesn't work that well. You need to treat about 20 patients to have one patient that would benefit from giving metoclopramide, at least at a 10 milligram dose. Dexamethasone, a great drug for prophylaxis, but is not a very good drug for treatment because it's slow onset. It doesn't work straight away, and when you have patients who are suffering from nausea and vomiting, you don't want to give a drug that works in 4 hours. Promethazine, a drug that works on multiple receptors, on the cholinergic, histamine, as well as dopaminergic receptors. But there's also issue with promethazine. As many of you know, that there's a warning about promethazine when you not inject it in the IV, it can cause tissue necrosis. And there have been reports that patients have to have their limbs amputated because of this tissue sloughing when the drug is out of the vasculature. Dopamine, a great drug, shown to be effective. Dopamine antagonists such as droperidol. Unfortunately, droperidol had a black box prolongation of QT intervals. And that really significantly impacted on the use of droperidol as a routine antiemetics. Dimenhydrinate, histamine antagonist, good drug, but it also comes with sedative properties. Aprepitant, an NK1 receptor antagonist, good for preventing vomiting. Unfortunately, is only available in an oral formulation, and therefore is not the best option when the patient is actively having vomiting or nausea. So there are some limitations on every of these potential options that we can use. So we are a bit limited by the choice of antiemetics when the patient needed it most. They had a prophylaxis, and now they're throwing up. The nurse is looking at you and said, "Doctor, do something." And you're scratching your head and say, "Well, you know, this drug has some side effects, I have problems. What do I do?" So there's clearly a need for developing additional antiemetics that can potentially could be used when the patient failed their prophylaxis. So because of these many pathways, so PONV is not as simple as just giving the drugs or giving 2 drugs. There are a multitude of factors to consider. And as I mentioned earlier, patients still experience PONV. And we know that ondansetron is very inexpensive, it's generic, it has its place, but it also has some limitations. Likewise, droperidol is also effective, but it also has some problems with QTc prolongation. And we talk about rescue, there is also a shortage of additional drugs that we can potentially use. So the bottom line is that there are opportunities for we to do better. What can you do when you go back on a Monday, back to your routine practice? There is something you can do. Number 1, think about how can we best treat my patients. Evaluate, does your institution have a protocol? If your institution does not have a protocol, maybe you can help formulate one. Given the information that I share with you today, you have a lot of information. You know what are the risk factors. Start off with that. You know the drugs that are effective. You can put in a protocol, these are first-line antiemetic prophylactic therapy. Use combination in high-risk patients. And you can also know that if you fail the prophylactic antiemetic therapy, what are the treatment options? So you have all this information that you can put together, and ultimately, if you are not doing an enhanced recovery protocol, I would encourage you to go back to an institution, talk to your surgeons, talk to the nurses, come up with a team that can then implement enhanced recovery, and I can tell you that it's very rewarding because you will see an improvement in your patient care. Also, you will help your institution in reducing healthcare costs, improving quality, improving patient satisfaction. Thank you very much for your attention.